You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about hibernation and stunning, which I think is a non-obvious topic to figure out, so it's important to go through. Let's start with definitions, and then we'll go over modalities for assessing viability, such as FDG PET, SPECT, dobutamine stress echo, and MRI. Then we'll go over interpretation of nuclear PET viability, interpretation of stress echo viability, and then finally the role of viability testing in today's world. Let's start with definitions. What is considered viable and what is not? Viable myocardium refers to any myocardium that has presence of living myocytes, irrespective of contractile function or responses to extrinsic stimuli. This includes metabolically active dysfunctional myocardium subtended by diseased coronary arteries with limited or absent scarring. Viable myocardium is myocardium that has the potential for functional recovery following revascularization. Ischemia, stunning, and hibernation are all considered under the category of viable. Infarction, or scar, is irreversible and considered non viable. Specifically, myocardial stunning refers to myocardium that has briefly suffered an acute ischemic insult with subsequent restoration of blood flow and is still alive and slowly recovering its contractile function, unless another ischemic insult ensues. Myocardial stunning occurs in patients after PCI or exercise induced myocardial ischemia. Recovery of the stunned myocardium eventually occurs but may take days to weeks. On a cellular level, stunning of myocardium occurs due to generation of oxygen-derived free radicals, calcium overload, and reduced sensitivity of myofilaments to calcium. Stunned myocardium does not respond to inotropic therapy, hence the appropriateness of temporarily inotropic support in some patients after myocardial infarction until the adjacent stunned myocardium recovers contractile function. What about myocardial hibernation? Hibernation is when chronic low blood flow results in metabolic adaptations allowing the cardiomyocytes to survive, but these cells do not demonstrate contracting motion at rest and they exhibit dedifferentiation morphology, which is not good. On a cellular level, hibernating myocardium involves a switch from aerobic FFA to anaerobic glucose metabolism, leading to a reduction in contractile filaments and degeneration of the sarcomers, leading to accumulation of glycogen and shrinking of mitochondria and the differentiation of myocytes. As a result, you have loss of membrane integrity and altered density of alpha and beta adrenergic receptors. Myocardial hibernation is an adaptive process that promotes myocyte survival over maintaining contractile function. These myocytes have achieved a steady state of reduced function to match the reduced myocardial perfusion so they can remain viable by a thread, basically. This may be mistaken as a scar unless you do an FDG study to pick up metabolic activity or a dobutamine stress echo to see its contractile reserve response. If revascularization by PCI or CABG is pursued, hibernating myocytes may take up to 1 year to fully recover after revascularization, much slower than myocardial stunning takes to recover after revascularization, although we typically assess it at 6 weeks. In myocardial infarction, myocardial cells die and are replaced by scar tissue and do not recover contractile function in the future. What are the four main modalities for assessing viability? There's FDG PET, where viability is defined as myocardial segments with decreased perfusion but with intact FDG metabolic activity. It identifies myocyte metabolic activity in the endocardium, myocardium, and epicardium. FDG PET. On SPECT nuclear stress test, viability is defined as myocardial segments with decreased perfusion with delayed uptake. It identifies cell membrane integrity in the endocardium, myocardium, and epicardium. On dobutamine stress echo, Viability is defined as wall motion abnormality at rest that improves with low dose dobutamine infusion. It identifies inotropic contractile reserve in the endocardium and inner myocardium. On MRI, viability is defined as delayed enhancement in 5 to 20 minutes, indicating fibrosis or scar. It identifies stunned myocardium. How do you interpret nuclear PET viability testing? It's actually quite simple. In all four conditions, ischemia, stunning, hibernation, and scar, stress perfusion will be abnormal and flow reserve will also be abnormal. Rest perfusion will be normal in ischemia and stunning, but abnormal in hibernation and scar. FDG metabolism will be normal in all situations except for scar, where FDG metabolism will be absent. Note that FDG metabolism will be preserved in hibernation. That's all you need to know about nuclear PET viability testing interpretation in just 3 bullet points. Now, how about interpretation of stress echo viability testing? This one is a bit more complicated, and I can't summarize this for you in just a few bullet points. In stress echo viability testing, dobutamine is started at 2.5 or 5 micrograms kg per minute and increased to 40 micrograms per kg per minute in 3 or 5 minute stages. The starting dose is intentionally low because at low doses, the inotropic effect of dobutamine is more prominent than its chronotropic effect, so you can get the contractile response without the tachycardia that occurs at higher doses that may lead to ischemia, which would blunt the expected increase in contraction of any viable segments. At baseline, at each stage, and in recovery, 4 sets of images are obtained in parasternal long axis, parasternal short axis, apical C, and apical 2C. Each myocardial segment is qualified as normal, hypokinetic, akinetic, or dyskinetic. Wall motion is interpreted in 3 stages: at rest, then at low dose dobutamine, then at high dose dobutamine. If the viable segment is supplied by a coronary artery with significant stenosis, the increase in heart rate will cause ischemia at some point, producing a biphasic response, an initial improvement in contractility at low dose dobutamine, and subsequent deterioration in contractility when ischemia supersedes. A biphasic response indicates hibernating myocardium, which has a high likelihood of functional recovery if revascularized. If the improvement in contractility is sustained at peak stress, that suggests a stunned segment. If the contractility worsens throughout, that suggests scar tissue mixed with normal tissue. If there's no change whatsoever with stress, that suggests scar. If 5 or more segments in the 16 segment model are considered viable, then the patient is considered to have significant myocardial viability. To repeat the above in simpler terms, normal tissue would show the following wall motion upon rest to low dose to high dose dobutamine: normal, better, better. Ischemia would be normal, worse, worse. Stunning would be hypokinetic or akinetic at rest, then better, then better. Hibernation would be hypokinetic or akinetic at rest, then better, then worse. Scar would be akinetic at rest and no response. The role of viability testing is very controversial. It was previously assumed that in patients with ischemic cardiomyopathy, the presence of significant myocardial viability, at least 25%, predicts improvement in survival and quality of life from CABG over medical therapy alone. However, the myocardial viability substudy of the STITCH trial called this into question, as assessment of viability did not identify patients with a survival benefit with CABG compared to medical therapy. It has been argued that the Stitches trial's negative result, the 5-year paper being published in 2015 and 10-year paper in 2019, does not mean the end of viability testing, because less than 50% of enrolled subjects underwent viability testing. Subjects were not randomized to viability testing, so there is some selection bias. Viability testing could be performed prior to, on the day of, or after study enrollment, so that not only was there selection or enrollment bias, but it probably influenced subsequent clinical decision making. Only 19% of subjects were deemed not to have viable myocardium, so there was limited power to detect a differential effect of revascularization. And they only studied SPECT and Dobutamine stress echo, which cannot be extrapolated to nuclear PET FDG testing or cardiac MRI testing. So the role of viability testing remains unclear today, and hopefully we'll get more guidance in the next set of guidelines. That's all for hibernation and stunning.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.